Um, I don't know what to literally ask. So, can you kind of just like go over those two, like the alpha
Uh,
receptors and the alpha blocker? Because I get confused on what they treat, what they don't treat,
yeah.
um, or kind of get it like backwards.
Okay. No, that's completely fine. The alpha receptors are part of the sympathetic nervous system. Are we good with that?
Yep, I know that part. So, yep.
Okay. So we have that, and then we have the beta ones, right? So the alpha blockers, they stop the sympathetic nervous system from doing anything in the peripheral. Because remember the alpha blockers were the ones that were sitting like anywhere besides the lungs and the heart. So when we have the alpha blocker medications, they can go anywhere and do anything that the sympathetic nervous system would do in the body, but we're going to block the receptor so that it can't turn that on or it can't do it. Um, but for some, the only medications that we're talking about for that are they're treating the bladder and they're treating the blood vessels. Um, so the blood vessels have muscles on them that the brain tells to constrict or to relax, depending if we want vasoconstriction or vasodilation. Um, so when the sympathetic nervous system tells the blood vessels to constrict, we're going to raise blood pressure. But if you have hypertension, we don't want that to happen. Just like even within our normal daily lives, we want to minimize the number of times that that happens. So we want to promote vasodilation by preventing the sympathetic nervous system from causing vasoconstriction. So that's the blood vessel part. And then when we do the bladder, we were treating urinary, try to think, it was urinary retention, right? So the bladder, right? When you have urinary retention, you're not getting a good urine flow. So what we don't want to happen to the bladder is for the bladder wall to relax so that it can hold more urine, and we don't want the sphincter to be clamped shut, which is both of those things are the bladder is told to do both of those things from the sympathetic nervous system. So we're putting the alpha blockers on those receptors in the bladder and the urethra so that the sympathetic nervous system can't tell the bladder to do those two things, so it won't make the symptoms of urinary retention worse. Does that help?
It does a little bit. So, when the bladder relax, it
Yes.
holds the okay, that's what I got backwards. I when I think of
Yeah.
relax is release, let go. That's how
Yeah.
I thought
Yeah.
about it. So when it relax, it holds the bladder.
Yeah, so, like, they
Okay.
kinda do the opposite. When we have the sympathetic, it relaxes the wall, but constricts the sphincter. And then when you have the parasympathetic, it constricts the walls, but it opens the sphincter. So it's kind of like for either one, the wall and the sphincter are doing the opposite. Does that make sense?
Mm-hmm.
So
Yeah,
they both
so,
contracted, but one is just releasing and one is holding it in. The
Mm.
parasympathetic is holding it in.
the parasympathetic is designed to make me go, and the sympathetic nervous system is designed to make me not pee.
Okay,
Um
okay.
So the sympathetic nervous system holds more urine so that as I'm running or fighting or whatever, like along those lines, I can hold more urine and I'm not having to go, right? But the parasympathetic nervous system is like, okay, we're safe, we can go again. So it's going to constrict the bladder walls to push that urine out. And then it's going to open that sphincter so that it can actually come out.
So
Okay.
it's no difference between alpha one and alpha two.
Not that you need to know, no. Just
Okay.
different locations in the body. They're all alpha receptors. I don't care.
And that's
Um,
what I wanted to ask too for the different locations in the body. So you said the peripheral, like tissues or parts of the body. So that would be like more so obviously the bladder because we're talking about it, but like the eyes and stuff.
yes.
Oh, okay. Because I get
So yeah,
confused that with glaucoma. Like,
yeah. So it would be the alpha receptors. You are correct. Yep.
okay, but what treat? So what would be the
So let me put it in
treatment of
perspective.
glaucoma? Okay.
So we have adrenergic we're going to talk about this actually in class today. So, we have adrenergic eye drops. All right. Um, so if I have the alpha receptors on my eyes, um, or on the blood vessels in my eyes, that type of thing, and it's going to simulate those receptors in my eyes to do different things to help with the pressure in my eye for glaucoma. Um, we'll go into it more like in class today because it's a whole thing. But does that kind of make sense? Like the alpha receptors would be in my eyes because it's not in my heart or my lungs, right? So there would be receptors in my eyes that I could target to turn on the sympathetic.
And that
So,
dilate, right?
It would dilate my pupils, yes.
Okay.
Among other things, yes.
so the alpha receptors will be the one that treat glaucoma, or will they be the anti-adrenergic that
So
treats glaucoma?
the adrenergic can treat glaucoma, but so can the cholinergic.
Oh,
I know that's confusing, and we're going to clarify that later today. But there's different mechanisms that the sympathetic nervous system can do to help glaucoma, and then there's different things that the parasympathetic nervous system can do to help glaucoma. So we have two different types of eye drops depending on exactly like how bad your glaucoma is or what part of it you have an issue with, or which one you have more success with. But basically, they're two different mechanisms of action that help both can help glaucoma. So does that make sense?
a little bit. I'm still kind of confused with it.
I know that the eyes aren't the best example. As long as you know the glaucoma, like the very basics of the glaucoma stuff that we talked about last week, you should be fine for this test. And then we'll go over the rest later today. So if you want to talk more about the alpha blockers and things like that, we should pick a different example. Um,
Well,
are you still?
so just to go back to the bladder real quick, so just to make sure I have this correct. So the
Yes,
adrenergic, that's going to treat overactive bladder. So an anti-adrenergic, that's going to treat urinary retention.
correct.
Okay, thank you.
Hmm. Yep, yep. Any other questions about alpha blockers or the alpha receptors? Anything I can make more clear?
So with the alpha, basically, because I guess I don't know. So when I was looking it up and it was saying like with the alpha one or even if it's beta one, they mainly just stimulates, and when it comes to like beta two, it relaxes, kind of. Cause like it relaxes, so it like bronchodilation for the lungs for beta two, and with beta one, it constricts, which causes hypertension, right?
Yeah, that would be, you don't need to know that for the test, but that would be true because the beta 1 receptors are in the heart, where you're going to want to control blood pressure. So you would have more of like I'm trying to think, with the beta 1s, they cause like tachycardia, right? Vasoconstriction, so that would be true. And then yeah, the beta 2s are in the lungs where yeah, they would need to relax the broncho muscles so you don't get bronchospasms. So that is correct, yeah. But you don't need to know it that in depth for the test. As long as you know where they're located and like what the drugs are doing in those areas, you should be good.
And she just said, so what she just say about it? So she said, what did Lauren just say again? Say that again, Lauren.
So I was just clarifying, make sure I had the correct understanding. So
Yes.
an adrenergic drug is going to treat urinary retention, whereas a anti-adrenergic is going to treat, no, I got it backwards, sorry.
Yeah,
An
yeah, other
adrenergic is
way.
going to treat overactive bladder, and an
Hmm.
anti-adrenergic is going to treat urinary retention.
Correct. Does that help?
Yeah,
Yeah,
that
because
part makes
everything
sense.
moving fast,
Okay.
right?
Yeah,
Like
that
you
makes
holding it in
sense.
during running,
Yeah.
basically.
Yeah.
Okay.
Perfect. Yeah, that's a
So
perfect summary. I love it.
if an anti-adrenergic would treat urinary retention, would a cholinergic also treat urinary retention?
Yep.
Okay.
Yep. You're getting it.
I just want to make sure.
Yeah, yeah. Because they're like the opposites attract, right? Does you kind of like see what I mean by that?
Yes.
Okay, perfect. Yeah, so you are correct. What else can I answer for you? This is just ask your questions and we will, you know, see what we can do to answer them.
So kind of dude. So dude, I don't know if I'm just repeating what Nicole just said. So do the
That's okay.
adrenergic blocking kind of work the same as cholinergic?
100%.
Okay.
They work differently, like with their mechanisms of action, but their effects on the body will be the same.
And then adrenergic and anticholinergic is kind of the same. Okay.
Mm-hmm. Mm-hmm. Yep. 100%.
I'm just looking at some of the notes I have. I have a note
Mm-hmm.
about Flomax. It says
Yes.
Tamsulosin. It says to know risk for bleeding and risk for hypertension. And my note that I wrote next to that said when taken with. I'm not sure what I meant by that. Do we need to know what it interacts like? Oh, so the alpha blockers interact with Flomax. Is that what
Yeah,
I'm?
yeah. So I think what we had said about that was when you take two alpha blockers together, it's too much. There's too much of the same thing going on. And in farm, that's like a common theme that you'll see with interactions. If you have like too much of the same type of drug, you're going to get toxicity. Or like you're going to get adverse effects. So with like two different types of alpha blockers, so whether it be like Flomax and Cardura or whatever two that you're taking together for different conditions, you have the risk of getting adverse effects, which in this case I believe were hypotension was the huge one. Otherwise, you don't need to know anything about like Flomax specifically, except that it's for urinary retention. Does that help?
Yes, thank you.
Oh, okay. All right. What else we got?
I guess for the nasal decongestions,
Hmm.
so that would be like the alpha one receptors will be like constricting it, right?
The alpha,
Causing,
well, just the alpha receptors in general. You don't need to know whether it's one or two. But
um,
yeah, because those are going to be targeting the blood vessels in the nose. The blood vessels in the
and
nose.
and since it's doing vasoconstriction, that's leading to like decreased nasal congestion, or no?
Yep,
Because,
yep. Vasoconstriction is leading to decreased nasal congestion.
but I thought constrict means like I don't know. I guess I'm just
So
trying to pair it with blood pressure, and I shouldn't because it.
no, it's different. It's so we need vasoconstriction to bring up our blood pressure and then to also stop nasal congestion. So the way nasal congestion works with the blood vessels in my nose, right? Um, I didn't teach you med surg, but both the when I have inflammation, like when I have, like seasonal allergies or a cold or whatever is triggering the nasal decongestion, it tends to cause vasodilation and vasopermeability. So that means that the blood vessels are going to open and that blood is going to be able to get out of the blood vessels into the tissues to cause the swelling, the redness, all of your inflammatory symptoms. Um, so that's happening in my nose with my blood vessels. So if I go and take an adrenergic decongestant, it's going to take those blood vessels and it's going to vasoconstrict them so that they can't leak out fluid and congest me anymore. Does that help?
Yeah, that makes sense.
Okay. Yeah. And then I think we do have anticholinergic decongestants that work similarly.
Will the math problems on this test be the same kind of as last? Okay.
Yep. Yep. They shouldn't really change. They should be consistent. All right. What else we got? How can I help you be better for the test tonight?
I guess to what extent do we need to have the drugs names memorized? And are we going to get generics on the test, or is it gonna be generic and name brand, or just one or the other?
For the most part, I do name brand or trade brand just because those are the more ones that you'll see. But basically, whichever ones were in the PowerPoint. So I believe a lot of them in the PowerPoint only gave you one name. Um, I know they were listed in like a sequence, but there was only one name. So the names I told you to focus on during the lecture, those would be the names that you need to know. But basically, yes, you do need to know what drug does everything for like each chapter. Just like which drug does urinary stuff, which drug does eye stuff, which drug does cardiac stuff. Does that make sense?
It does. That's just the part I'm most nervous about. I think I understand like the concept of how each category works. And then I'm looking at these drugs and I'm like, I'm not an LPN. I know a lot of people in the class are. A lot of these drugs I've never seen before in my life. So I
Yeah,
guess I'm
yeah.
gonna be focusing on that before the test.
I know even to me, a lot of them aren't familiar. So if that helps. So you're going to see some of these drugs all the time, and then some of them you're never going to see again. So unfortunately, with farm, yeah, you have to know them anyway for the test. um, that's just a memorization thing. I don't know if flashcards help or however you memorize the best.
Well, we got 2 hours, so I'm gonna cram, but
Okay.
I did have a question. Will we be
Yes, ma'am.
focusing on like atropine overdose and like dish toxicity or what was it, beta something syndrome or any of that?
Nope. The only thing that you need to know like that is cholinergic toxicity.
Okay, cholinergic toxicity.
which would be like
Um,
the sludge, right?
Right?
That's that
And then
atropine,
yes, and then atropine is the
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 antidote.
treatment,
treatments, the
the
treatment.
antidote.
Yeah, and then when it gets bad, like later stage, that's where you get like cardiac or like cardiac lung like failure, things like that. And then that's when you need epi.
Okay,
Okay.
Why do
so
you
And then
need epi
the
if
oh,
you're giving atropine? Because when I was reading, it said like in low doses, when atropine is given in low doses, it causes like slowed heart rate or lower heart rate, but in high doses, it causes increased heart rate. Why do you need, if it's given in a high dose, why do you need to follow up with EpiPen or epinephrine also?
Good question. Because you may not catch it in the early stage. Um, so if you don't even get the opportunity to treat with epinephrine or with atropine, then you're going to have to go straight to epinephrine. However, um, atropine is an anticholinergic, right? So this is cholinergic toxicity, too much cholinergic going on. So we're first going to treat it with a anticholinergic, which is atropine in the early stage. And then if that doesn't work, because we're hoping that that works. We're hoping that we don't have to give anything else. However, if the symptoms can persist and they get worse, then we're going to have to hit you with a really hard hitter, which is going to be the exact opposite of a cholinergic, which is an adrenergic, and we're going to give you straight up epinephrine, like you're having anaphylactic shock.
Mhm.
Does that help?
Yes.
Okay, because the late stage is like you're gonna die like very quickly. So epinephrine is going to be your best bet for that. Where atropine is more of a tamer drug when it's not that bad. So we're hoping we don't have to go to epi, but it just depends on the patient.
Okay.
Okay.
so when we think about I guess the side effects
Hmm.
of a cholinergic, it will be sludge, but if it's more worse, you could think of it as sludge and airway since it causes like the respiratory.
So the toxicity looks a little bit different. I'm just going to share my screen. Give me 1 second. Um, let me share my entire screen. I want to show, let me bring that up. So can you guys see the PowerPoint?
Yeah.
Okay, so I want to show you the adverse effects here. They kind of look similar to sludge, right? You have the abdominal cramping, the increased secretions, the nausea, vomiting, diarrhea. You have think what was else? You had urinary incontinence one.
Yeah.
Yeah, so we don't really have that on our list here. But then when you go to the toxicity, sorry, and then let me see. So basically everything that's on this, yeah, you're pretty much right. I just kind of wanted to show you the compare and contrast here. Most of the symptoms that you're going to see on sludge are my adverse effects for cholinergics. However, when it gets to the later stages, this you're not super going to see, but if we go back, you're going to see that kind of like with the increased risk for bronchospasms, and with the Brady and like with the heart rate and the blood pressure and the syncope, things like that. So they kind of match. So like all of these together kind of equal the early and the late symptoms. Does that make sense?
Yes.
Okay. Does that help?
Yes.
Okay. Okay. Great. All right. What else we got?
So the medicines that's on the PowerPoint is will there be other medicines besides those ones or those ones only?
Mhm. Just those. Just those. What else can I clarify?
And
Answer.
then I was gonna say for the I don't know how to say the words nicotinic or
Yeah.
um so will we
Muscarinic
be focusing yeah, will we be focusing on the drugs that kind of correlate with those
receptors.
receptors, or will we be focusing on what those receptors do in the body?
Um, so what those receptors do in the body would be everything that the parasympathetic nervous system does.
Right.
So you will need to know that. And then yes, you need to know the drugs because those would be your cholinergic drugs.
Okay.
Okay, does that help?
Yeah. Yeah.
Okay. What else we got?
Okay. Okay, so I don't know if this will help anybody else or if it's just me, but this is my like silly way of thinking about the nicotinic and
Mhm.
muscarinic receptors. So nicotine, like I hate to say it like this, but when you smoke a cigarette, you get like lightheaded. So I always think of just like I don't know, I always think of nicotinic as like central, and then muscarinic, I think of mucous membranes. Those are more peripheral. So that's it's
Yeah.
like just my like dumbed down way of thinking of it.
No, that's perfect. Thank you. All right. What else can I answer? Um, any other questions, concerns?
I know I'm gonna have 1,000 questions as soon as we get off of here. Um,
Well,
but otherwise, thanks for your time. Much appreciated.
you're welcome.
I just got on. Was this for the last test that we went over, or is this for the one today?
This is just like any questions, concerns for the one today.
Oh, okay. Okay. Yeah, I can't think of anything right now either off bag. I'm off guard. But
Okay.
Do we need
Enough.
to know like I guess what diseases that these uh receptors or target like for the cholinergic drugs, we know that it helps with Parkinson's, right?
Hmm.
And I guess Alzheimer's. So is that like something that we need to know like
Yes.
that, right? Okay.
You need to know the drugs. Like Aricept is for Parkinson's or Alzheimer's.
Say that drug name again.
Aricept or
Or
donazepam,
donepezil.
Desmond.
or yeah,
Okay,
whatever.
I
Yeah, sure.
recognize it by that. Okay.
Okay, yeah. Sorry, I always just call it Aricept. But yeah, you do need to know those.
Okay.
Hmm.
See, that's what makes me nervous is I feel like a lot of our texts and stuff, it's all the generic, and I don't know. Like I might know a drug by its generic name. Like I know donepezil, however you say it, but I've never even heard of it being called Aricept before. So
Really? Okay.
that's what
I'm
I'm
Me
sorry.
scared.
either.
I mean,
That's
I
why I
see it.
said
I'm
what? Like what is
I'm
that?
sorry.
as soon as you
But
said the name, the generic, I'm like, oh yeah.
you're like, yeah, I know that. And then, oh wait, what the heck is that drug? Yeah, I know. All right, what else we got? Did putting the link into the URL or putting the URL link into the box and hitting enter, did that bring up the recording from last time? Did anybody try that? No one had an issue accessing that?
It didn't work
It didn't work?
for y'all last tutor session.
Yeah.
Yeah, it didn't work.
Okay. I will try to figure that out.
Okay, the Maya, the Gravis disease,
Mm-hmm.
is that the one where they like have the sludge systems when they be drooling?
Yeah, it's more like muscle, like widespread body weakness or muscle weakness, or it can target certain areas, like for muscle weakness too, just depending on how it affects your patient.
Okay, so that's the ones that's treated with the anticholinergic. Okay.
I believe so.
Okay.
I'm looking at the PowerPoint and it says, at least I'm looking at the chapter 21. It
Yeah.
says that it cholinergic is used for diagnosis and treatment of myasthenia gravis.
Is it? Yeah, sometimes
Yeah,
we
I
get
was
confused.
just
Okay,
about to
then it's
ask that
cholinergic.
because
Yeah.
I was about to say,
Yeah.
huh? Now I'm back confused.
I'm sorry. I know sometimes I can't keep it straight. Yes, it is cholinergic. I'm sorry. And then yes, Parkinson's is anticholinergic. Yes, I apologize. I know it's vice
So
versa, so
all
yes.
so Alzheimer's and myasthenia gravis are both going to be cholinergic.
Yes.
Parkinson's anticholinergic.
Yes,
Okay.
thank you. Yes. Yes. I was getting there, I promise.
No, you're fine.
Um,
Just saying it out loud helps me remember.
yes, yes, you are correct. Oh, alright. What else can we clarify, make better? New. No one has any other questions? Okay, so are we done? Or do you guys need me to continue answering questions?
Can you just break down indirect versus direct stimulation again?
Indirect versus direct stimulation?
Yep.
You don't need to know that for the test. Don't worry about that. That's too much. We skipped through that in the PowerPoint. Don't worry about that.
Okay, thank you.
Yeah, because
Is
that was
these?
like,
Oh,
yeah,
I'm
sorry.
sorry. Go ahead.
Oh no, I was just saying I was just trying to keep this all very as less complicated as it could. So we don't need to worry about that. But yes, what was your question?
My question was, are you going to be offering these tutor sessions like every week?
I can try, yes.
Okay.
Yes.
I feel like it just goes so much better when we're not all zooming from the same place. Like we can all like hear each other and hear ourselves, and
Yeah,
just
I completely get it. Yes, I will try to have one every week. Does it work better on Tuesdays or Thursdays?
well, I think in the future some of us like we have a clinical that starts in a few weeks, so some of us will have clinical on Thursdays going forward, but
Okay, so maybe
not
Tuesdays
everybody.
then.
Yeah, Tuesday is definitely better for me.
Tuesdays would work
Okay.
better for me just because I know I am in the Thursday clinical.
Yeah, we can do Tuesdays. I can do another one next Tuesday for sure, before like around the same time. Because I teach in the morning. Here I teach nutrition, so yeah, in the afternoon before I leave to go get ready for your class, for sure. We can do that. All right, what else can I help you with? Any questions, concerns? Because I teach everything, guys. I teach all the med surges, I teach both farms, and I teach nutrition here. So any question you got about this, I can more than happy to answer it.
It's probably hard to, I don't know, for me, it's hard to think of any because I don't know what to expect on the test. I probably have 100,000 of them after.
I wish I had an answer for that, but the test will be similar questions to the like question formats and stuff to the last test. That's all I can tell you.
So looking at, I guess I'm looking at the adverse effects of the cholinergic drugs, like we were talking about cholinergic toxicity. So
Hmm.
I guess just looking at it, one thing that makes me nervous is seeing bradycardia or tachycardia, hypotension or hypertension. Like it can go
Yeah,
either way.
yeah, because it depends on how it affects the patient. That is set on there because it can cause heart rate and blood pressure fluctuations. So like that's what it means, like or like basically it can go up and down for heart rate or BP. But if I ask you a question on that, it'll make sense. Like it's not going to be like something crazy that like would take that out of proportion. So as long as you know
Okay,
that it
thank you.
causes like, yeah, the fluctuations, you should be good.
Okay,
Yep.
thank you.
Yep. Uh, has anybody done any practice questions?
Yes.
Okay. And where did you do the practice questions at?
I know a classmate had printed out like a packet for us to try, and it seemed like when I did some of them, it was pretty like, oh, okay, yeah, I get it, I understand. But I know on the test is, I feel like I'm not gonna understand. As in, um,
Yeah, tell me why.
I don't know, because my mind always just goes blank.
Okay.
Like now, like we talking about it and going over it, and you talking about it, it makes sense. Um,
Okay.
Me going over my notes and listening to you and everything, I'm like, okay, I'm on the same page. But then it's like when I take the test, I'm just dumbfounded.
Okay. So is it test anxiety? Is that the
I mean, I have it, but I don't know. I just don't know.
um yeah, so the the biggest thing I can tell you for test anxiety is just to take your time and don't second guess yourself on the exam. But the biggest thing with these nursing exams is just you have to figure out what it's asking you. And you have to figure out like look for the keywords and try to figure out like priority wise, like what's going to kill my patient first when it asks for a priority, right? Things like that. And it's asking for more like connections, like what do you see like this is causing like more of like a sequence of events or things like that. Does I don't know. I know I can't help you with when you get to the test, but um, that's why maybe I was hoping practice questions maybe would boost a little of the confidence in answering those type of questions.
I think
We
it
had
does help. Oh, sorry. I think it does help, but it's like when I take the real test, I get humbled real quick. Like after I see my score, I be like, cause I really thought on the first test, I thought I knew that stuff, the basic stuff.
Mhm.
I thought I did okay, but I didn't like my score. So I was like, oh man, I really thought I knew something, but I guess I didn't. So,
Okay. Nicole, what were you going to say?
I know I had tried a couple different routes for quizzing myself. I had put all of our slides into AI and like had it like create like, NCLEX like style quizzes, and then
Hmm.
there was the one that she's talking about, our classmate printed out, and there's an example of like a question where I get kind of stumbled up. If am I allowed to read it and give you like
Yeah.
an example?
Yeah, for
Um,
sure.
it says a patient presents with flushed, hot skin, dilated pupils, absent bowel sounds, urinary retention, heart rate 128, BPM or BPM, temperature 104, confusion, hallucinations. And it says cholerogenic crisis, androgenic crisis, anticholerogenic toxidrome, and serotonin syndrome. And the answer was anticholerogenic toxidrome, but sometimes I get confused between the anticholinergic and the um
Adrenergic.
yeah, crisis. Yeah. I think that's what happens to me on the test. Like when I'm studying, I'm like, okay, like I feel like I got them untangled and then they kind of
Okay.
retangle sometimes.
Okay. Yeah, that question I would have thought it would have been adrenergic toxicity too. Um, I'm trying to think of how did
And
you
AI is not always right. I feel like AI can sometimes
Yeah.
like that. Maybe
Yeah.
maybe maybe that would be an adrenergic crisis.
I'm
Yeah.
not familiar with that one. It was called Claude. One of the
Okay.
students, but I'm not familiar with that one, but um, yeah, that was I don't, so I'm not sure, but
Yeah, that was a very bad question.
okay.
Did you
Okay.
guys try Yeah, that I don't like that question. I would not put anything like that on the test. But did anybody try using SurePath AI?
I haven't yet. I know we used to use it. I haven't gone back to it. That's probably a good idea. I haven't used it in a while.
Okay, because I know you can't like copy and paste or you can't like upload anything into it, but you could like copy and paste PowerPoint slides and things like that into it and then just ask for critical thinking based NCLEX practice questions with the rationale and answer. Because if you read the rationales and you learn like, okay, why was this correct? What was it asking? It'll hopefully help you detect that and like other questions. And then also, the SharePath AI is a great resource to further break down information to, as long as you're very specific with what you're asking it, and it can make you like use study guides, review things. So it's a great resource, and it comes directly from your book.
This one, it gave an explanation as to why that was correct. And I've seen this saying before. I don't know if you've heard this. It says classic anticholinergic toxidrome, dry as a bone, no sweating, red as a beet, flushed, blind as a bat, dilated pupils, hot as a hare, hyperthermia, mad as a hatter, confusion, hallucinations, full as a flask, urinary retention, plus tachycardia, and absent bowel sounds. Treatment includes, I don't know how to say this one, but it's cytamine,
I have to
tag.
see it like written out, but
It's one of the ones that it's gone over in our slides, but it's yeah. I don't know if you've
okay.
heard
I
it
have
say.
not, but I guess the only thing that does clue me in that that's an anticholinergic and not an adrenergic is the psychosis involved with it. Um,
Okay.
Yeah, because when you got too many or too much of an anticholinergic, I believe it causes hallucinations, psychosis, delusions.
Okay, yeah.
Um, yeah, so that would be the only thing that would differentiate that from me from adrenergic.
Okay.
Yeah, but I'm not going to give you a question like that. If I give you a question, it's going to be cholinergic toxicity because that's the one we talked about.
Okay.
Yeah, but I appreciate the example. Thank you. Um, Otherwise, in terms of trying to help you differentiate it, um, there's nothing that can really, that's just part of studying. Like, I don't think that there's any like advice I can give you to make it so you don't mix things up. Um, do you guys have a line piece? Does Miss Neil let you use a line piece of paper?
I think she gives us the blank sheets when we start.
Okay. And that's so you can like write things out on the test, right? If you want to.
Yes.
Okay. When obviously you can't write on it before, but once the test starts, you could take like 10 minutes and write everything out really quick, and then you can look back at it as you're answering questions. Would that help?
That's what I was going to try on this test because it's
Yeah.
so much of, you know, the opposite and vice
Yeah.
versa of both of the PNS and CNS and all that stuff. So
Yeah, and that way you can just kind of like blah, regurgitate it onto the piece of paper. And then when you're taking your tests, you maybe don't have to think about things as much or go blank because you can just refer back to the piece of paper once you start the exam and you write it out.
That's a good idea. Yeah.
Okay.
Someone had mentioned that
I
before in
do
our
that.
previous
I do that
episode.
with the math formulas sometimes. I'll
Okay.
like at the
Yeah.
beginning of the test when she gives us a paper, I just jot down a quick couple formulas. So if I need to refer back, I can.
Yeah. So yeah,
Yeah,
maybe
good
yeah,
idea.
yeah, maybe try doing that so that way at least maybe you have like something to visually look back at you to cue you so it's not doesn't get all scrambled with the test anxiety. Okay. Otherwise, I'm not sure how I can help them not get confused because that's kind of the bad thing about these chapters. So, like I said, I even struggle with it. Sometimes I don't even remember what goes where. So,
Is
yeah.
there quite a few select all that apply on this test?
I don't know the count, but there is always a few, yes.
I know those trick us up quite a bit, many of
Yes.
us.
Are you guys not used to getting them?
I
Here and
mean,
there, but it seems like we're getting more from my opinion anyhow. But
Yeah. Um, that's just because you're going to have a ton of select all that applies in your NCLEX.
right.
Yeah.
Right.
So the more you get, I mean, I don't like make like my whole test like half select all that applies. Um, it just kind of depends on the questions that I find, and if they're a good question, I'll just pick it regardless if it's select all that applies or not. Um, but the more you get used to answering them, hopefully the edge will be taken off when you do the NCLEX and the green light and stuff like that.
Right. Okay.
Yeah, but hopefully there's not a ton of them.
Hopefully.
Looking at the PowerPoint, I'm looking at chapter 21, the cholinergic blocking drugs, and I'm noticing that mirvetric is listed, but it was also, I know cholinergic blocking and adrenergic have similar, as we talked about, like different mechanisms, but similar results, but it looks like that
Mhm.
drug is listed for both
Yep.
adrenergic and cholinergic blocking.
That
Okay,
was the one fun one, yeah, that was for both, because I think it works on both nervous
okay,
systems. Yeah, yeah. So, like, it
okay,
promotes the
got it.
adrenergic, and then it blocks the parasympathetic.
That makes
what,
sense.
what drug
Mhm.
was that?
Myrbetriq for the
Oh,
bladder, issue. What is it? Bladder, overactive bladder. It was an adrenergic and an anticholinergic, but that was the only one that had, like, a dual, uh, label or class. So and obviously, I took that into consideration when I made the test, so I'm not gonna, like, trip you up on that. All right. Any other questions, advice, anything I can help you with before we move forward here and you go home and or you go do whatever you're going to do before the test? anything about the content that doesn't make sense. Still, any clarifications, any test questions?
I think I'm good. Thank you. I appreciate it.
Okay, you're welcome. Thank you. Anyone else need anything before we hop off here?
Thank you.
You're welcome.
Yep, I'm good. Thank you.
Okay, thank you. I appreciate it.
I appreciate it. Thank you.
You're welcome. Everybody else good? Anybody else need anything before I hit end here?
No, like else said before, I'm sure we're gonna have a million questions after.
Of
But
course.
thank you.
You're welcome. All right, I'm gonna hit end. But if you need something else between now and then, just email me, okay? And I will see you all tonight. Good luck on your test.